Her interests includes geriatric psychiatry, cultural psychiatry, dementia care, integrated care, palliative care, psychotherapy, and ethics. Thank you, Dr. Shimizu. Take it away.
Thank you so much for your kind introduction, and hi everybody. I'm Mariko.
Aloha.
Hello, nice to be here. Thank you so much for having me. So let me share my screen, and as I do it, I apologize. My computer's kind of old and it's starting to make weird noise, so I apologize in advance. Sorry. There you go. Okay, do you all see my slides? Yeah, all right. Great.
Yes.
So let me adjust my screen so that I can see what I'm presenting. So today I am going to talk about management of psychotropic medications, focusing on two major categories of psychiatric illnesses that you probably see a lot in the patients or clients that you work with. The first category is psychotic disorders, and the second category is bipolar spectrum disorders. So I'm just going to spend a little time talking about it. As an introduction, I have no disclosures. And by the time you're done with this session, I'm hoping that you can gain some basic understanding of different psychotropic medications commonly prescribed for people with psychotic disorders and bipolar spectrum disorders in the settings that you see them. And also, I'm hoping that you can learn something about, indications and side effects of commonly prescribed psychotropic medications. And as I mentioned earlier, I have two parts to this presentation. The first part, psychotic disorders, the second part, bipolar spectrum disorders. I'm hoping to spend maybe like 15 minutes each. And so,
Hindi, sige na, nakikinig na ako eh.
Is everything okay? Do you hear me okay?
Ha?
All right. So moving on to psychotic disorders. So what are psychotic disorders? So simply put, psychotic disorders, it's in psychiatry, we have different kinds of illnesses that we treat, obviously, and we categorize different disorders into big groups. So psychotic disorders is one group, and those disorders are characterized by symptoms like delusions. People believe in things that's not based on reality, paranoid delusions. Some people think somebody's after them when there's nobody. They think, people are watching them when there's nobody watching them. So that's, delusions. It's a belief not based on reality. And some people with psychotic disorders or psychosis, they experience hallucinations, meaning they see or hear or feel, smell things that's not really there. So delusions or beliefs, and hallucinations are perceptual experiences. So really, psychotic disorders are characterized by those thoughts and perceptual disturbances. And we can group them into, or there are different kinds of disorders to kind of break it down. And I've listed some of them for your for you to see. But schizophrenia spectrum disorders, those things include brief psychotic disorder, schizophreniform disorder, schizophrenia. They all present similarly, but they have different names because of the durations. So from day 1 to 1 month, we call it brief psychotic disorder. Schizophreniform is between 1 month to 6 months, and then schizophrenia anytime after or more than 6 months. So symptoms are the same, durations are different names. Schizoaffective disorder, I think some of you might have seen this diagnosis, but people are always having psychotic disorders, and sometimes they have mood episodes like depressive, hypomanic, or manic episodes. Delusional disorder, people are always delusional, but they don't have hallucination or perceptual disturbances. And for all these disorders within the psychotic disorder category, we commonly use medication, antipsychotics. And so I've listed some of the antipsychotics that you might have seen, and those are categorized in different, I guess, classes as well, but they all have pretty common side effects, so I'm going to go over that. So looking at first generation or typical antipsychotics, probably what you've seen the most is Haldol. And second generation antipsychotics, they might look more familiar to you. Nowadays, there aren't too many occasions where we use first generation for the side effect profile. So you probably see more of a second generation antipsychotics. So their side effects, so we talked about indications. So some antipsychotics are for psychotic disorders, and side effects depend on how strongly the each medication binds to dopamine receptors to address psychotic symptoms. But those medications, depending on which one you're working with, can have different nuances. They bind to different receptors too, so they have slightly different side effect profiles, but we can divide those side effect profiles into two groups. One is the movement-based side effect or extrapyramidal symptoms, and the second major category is the metabolic syndrome or metabolic side effect. So extrapyramidal symptoms, or movement-related symptoms or side effects. Those are some of the examples. And one is the Parkinsonian symptoms. This doesn't mean that the person has Parkinson's disease, because this is caused by medication. This is a medication side effect. And I've taken this illustration from online, and I didn't put the credit, sorry. But so those are kind of like the symptoms that you see: resting tremors, rigidity. Cogwheel rigidity means that you know what cogwheel is. Like when you check for the rigidity, it's not smooth like that. It's like cogwheel. You kind of feel the resistance, and it gets it's easy first, and then it gets harder, and then it gets easy first and then harder. So that's why it's called cogwheel rigidity. It's a pretty common symptoms, part of Parkinsonian symptoms. And sometimes you might notice that the patients have kind of flat affect, and they move very slowly. We call it bradykinesia. And so that's one category of within the movement-related side effects. The second big category is akathisia. What it means is that there are two parts to it. One is the objective sense, and then the subjective sense. So objectively, you see the person looks really restless, and they cannot sit still. They might look agitated, or some people say manic or activated. So they just really look really uncomfortable. And subjectively, the patient says, they're really not, dysphoric. They're really, this is something really bothering them, and they're highly anxious. So this is, the big category of side effect that you really should pay attention to, because some people think that they're like that because they're psychotic, and then they, sometimes try to increase the antipsychotics, which might make akathisia worse. So you try to treat it, and then you can actually make it worse by increasing the medication. So that's akathisia. And dystonia is like massive muscle spasm. It's usually seen immediately after the person started on antipsychotics, so you might not see that necessarily. And so among those things, I will say akathisia is one thing that you should really pay attention to. And it will be really helpful if you can, communicate with the patient's doctor about this. That way the doctor can determine what to do with the medication. And without your input, it's going to be kind of hard to decide what to do. And the last category of extrapyramidal symptoms is tardive dyskinesia. So it's by definition by NIH, it's a movement disorder characterized by uncontrollable, abnormal, repetitive movements of the face, torso, essentially any parts of the body. I've listed some little animation on the right, but you can see in blinkings, you can see in perioral or oral movements and things like that. I think the key is it's not voluntary, and it doesn't stop. And the tricky thing is that antipsychotics can cause these symptoms, but the mental illness itself can cause tardive dyskinesia. It's a little bit hard to see, but most of the time, tardive dyskinesia is seen in the first few years of treatment with antipsychotics. Again, I think your observation will be really critical. And if you could communicate that with the patient's psychiatrist or PCP, that would be really, really helpful, because there's a medication that we can give to relieve the symptoms. And so the second category, big category of antipsychotics is metabolic syndrome. And there are different kind of theories of how it causes it. Some people say because of antipsychotics, people eat more. There are some people saying that, because of the medications, the insulin resistance will increase, and then there's a physiological consequences with that will lead to diabetes and all these metabolic disorders. And I think one thing to remember for you is there's certain antipsychotics that raises the risk over the others, and those are clozapine or clozaril, olanzapine or Zyprexa, or quetiapine or Seroquel, but not so much with risperidone, debrasidone or Geodon or Abilify or Piprazole. And so for you, I think it's going to be so helpful for your patients if you can kind of monitor their weight really regularly and make sure that they work with a primary doctor to kind of check their blood sugar, lipids, cholesterol, all these metabolic things on a regular basis. And make sure that they eat healthy, and hopefully they can get some exercise so that they don't develop diabetes, or if they have it, they don't get worse. I think just kind of going through this briefly. Another thing about antipsychotics is that some formulation come in long-acting injectables. I think you might have heard of that or seen this, but most of the time it's once a month shot that they don't have to take the oral form every day. And it's really helpful for people who tend to forget, or they kind of tend to be a little ambivalent about medications. So I just wanted to kind of point it out. It's pretty effective in terms of people on long-acting injectables. They have a lower risk of getting admitted to the hospital, so they can stay in the community longer without getting admitted in the inpatient setting. So that's the beauty of it. And antipsychotics can affect the heart activities, the electrical activities in the heart. So that's something to really monitor as well. That the patient should work with a PCP and psychiatrist. And I know you have, or you already had the sessions about dementia, but using antipsychotics for people with dementia, there is a black box warning that it can increase the mortality or death rates, and that's the fact. So, but the thing is that we have to use it. So the important thing is to keep monitoring it and make sure that the patient and their surrogate decision maker is agreeable to using that medication. So just to kind of wrap up the first part, the key points are that people who have psychotic disorders are often treated with antipsychotics. And so it's important to monitor for any involuntary abnormal movements, as well as weight, oral intake, diet pattern, exercise patterns. And if you could work with the patient's doctors, if you observe any, restlessness, uncomfortable, looking uncomfortable, anxiety, all these things, after adjusting antipsychotic medication will be very important to catch the akathisia, which is known side effect, but often missed. So that's part one. So sorry, I went over time a little bit. Moving on to bipolar spectrum.
This is Juliana. I want to interrupt really quick. There was a question in the chat asking if it's the same as Parkinson. And I think Aurora, if you want to unmute and if you want to explain your question a little more if necessary. But.
My client has Parkinson, and her eyes are always rolling. Even her hands are shaking. So I was just wondering if that's also part of the dyskinesia. My client, and the other client also keeps moving his tongue unintentionally. Yeah, is that the same thing then?
Yeah. So it's really so I think there are two parts to the your question, right? The Parkinson's and then also the tardive dyskinesia. So Parkinson's, some people do have Parkinson's disease to begin with, and that's caused by not having dopaminergic neurons in their nervous system. So it's not induced by medications. So that's kind of like a neurological disorder, and that's Parkinson's disease. What I talked about here is Parkinsonian symptoms caused by antipsychotic medications. So people do have, the neurons in their brains. but they are demonstrating Parkinsonian symptoms because of the medications that they're taking. So but there are some people, people with Parkinson's disease who need to take antipsychotic medications that can worsen Parkinsonian symptoms. So in those cases, what doctors typically do is to prescribe medication, antipsychotics that tend to cause less Parkinsonian symptoms like Seroquel or quetiapine, or really rarely clozapine or clozaril. There's medication called pimavanserin that's approved for psychosis for people who have Parkinson's disorders. So, whether the person has Parkinson's disease or not, if the symptoms are worse, with the medication they're taking, it's probably very important to let the doctor know so that, they can adjust the dose. And for the tardive dyskinesia, so tardive dyskinesia and Parkinsonian symptoms look very differently. So, like you mentioned about blinking, I think, but Parkinsonian people with Parkinson's disease, they don't have many blinkings. It's probably like that, right? So when they're, presenting with excessive blinking, it's less likely Parkinsonian side effect from that medication. So it's probably, and if the person is on antipsychotics for a while, so it's better to let the patient's doctor know that the patient is blinking a lot, or hopefully the doctor can see it at the time of visit. But if it's getting worse, then it's worth mentioning. So it might be that that person might be developing some TD, unfortunately. So did I answer your question?
Yes, you did. Thank you.
Yeah, it's really difficult. And if you, and we don't expect you to catch it, because it's doctor's job to really catch it and then treat it. But it's so important, so helpful if you can just let us know what you've noticed, because you see the person every day, right? And you notice the differences and nuances. So if you notice that, it's always been there, but then this is getting worse, or, this is really interfering with this person's life, then, we kind of have to think about, okay, do we decrease the medication? Do we add something, to make their lives a little bit better? So, yeah.
Thank you.
Okay. Are we good? So maybe we can go to the next category, bipolar spectrum disorders. So I put bipolar spectrum because it comes in different shades, I guess. And, depending on the duration, depending on the severity. Oh, yes.
Then they are in order. Oh my gosh. Thank you.
Oh, okay. So
guys have to unmute please, because we cannot hear the other stuff.
Mute, supposed to be mute.
Okay, thank you. Yeah, so bipolar spectrum. So it does come in different flavors within that category, depending on the severity and duration of the mood episodes. And sometimes some people can have psychotic symptoms with bipolar. So it kind of, complicates the picture. So for that reason, typically people with bipolar, we treat it with a combination of different medications. Probably the core combination will be antipsychotics and mood stabilizers, sometimes, plus minus antidepressant. So for here, we already talked about antipsychotics, so I'm gonna talk about mood stabilizers. And so here are the commonly used mood stabilizers you might have seen: lithium, Valproate or valproic acid, Depakote, Carbamazepine, which is Tegretol, and lamotrigine, which is Lamictal. So let's start with lithium. So I took this image from Wikipedia. I just wanted to, show you that it looks like this in the natural form. It's a naturally occurring mineral. So it's used for mania when people are more elevated, they're hyperactive, they're talking all the time. So it's a manic episode. We use it, as well as maintenance treatment for bipolar. And so the thing about lithium is that it can affect kidney, thyroid, heart. And so it's a tricky medication because it has a strict therapeutic index. What it means is that it has to be at the certain level in the blood, and if you cannot miss it. If the concentration in the blood is below what's supposed to be, it might not treat the symptoms enough. But if it's above, you can get really sick. So it's very important to make sure that the person who's on lithium takes the medication regularly and also stay hydrated. So what happens, when the person has too much lithium, right? Toxicity. So sometimes you might see tremors, nausea, diarrhea, ataxia, meaning wobbly gait, unstable gait, and seizure even. And just be really careful when somebody starts losing water in the body, it kind of concentrates the blood, right? Which means that lithium level can go up in the body. So that person can, even if the person's taking the same dose of lithium, they might, end up having a higher concentration of lithium in the blood. So you might see some of those toxicity signs that we really want to catch. When things get so bad, or when the lithium is too much in the body, it shuts down the kidney, and it quickly goes to coma and death. So it's very important to catch, those signs really early, and then seek help in emergency department so that they can check the labs and they can check the lithium levels. So pay particular attention to people who have decreased appetite and fluid intake for that reason. But when it's used, it's very, very effective. It's one of the best medications that we can offer in psychiatry, in that it does reduce a death by suicide, and people get really stable on it. Some people even argue that it might have neuroprotective effects, meaning that their cognitive function might be well preserved when they're started on lithium for a long time. So when it's used in the right way, it's very effective, but just be really careful, especially when the person is not eating or drinking well. Especially in Hawaii, things that, it's so hot, so people can lose water by, sweats and stuff a lot more. So something to be careful of. So the next one is valproic acid, or Depakote. It's also used for mania and maintenance therapy. The good thing about Depakote is that it's more forgiving in terms of the dosing range. So lower risk of toxicity. It can be especially helpful for people with anxiety, as well as some agitation, kind of impulsive, kind of violent type of profile. And major side effects, there are all kinds of things, but I think what people complain the most is weight gain, sedation, cognitive impairment. They feel like their mind's not working too well. And side effects are dose dependent, and we have to check for the liver function test because it can affect the liver. And I don't know if it's relevant to your clients, but this is a medication that we should avoid in people who are childbearing age, because it does affect the baby or fetus. And I just want to put those pictures in the bottom, because the good thing about Depakote is that it comes in different forms. So, standard pills tend to get kind of big, so that people don't like it. But and the middle one is the sprinkle, and the one on the left is Depakine, is the liquid form. So depending on whether the person's preference, or whatever the reason is, some people have a hard time swallowing the big pills, and then they might prefer liquid form or just sprinkles. And carbamazepine, or Tegretol. So it's used for not mania, but bipolar depression and maintenance. And it's not really widely used. I actually have not seen people taking this too much, because it interacts with pretty much every medication that we can think of. And the beauty of it is that it does not cause weight gain like any other, typically, I think psych medication tend to cause weight gain a lot, but this one doesn't. So that might be a benefit of it, especially when we're concerned about the metabolic side effect. But something to really remember if your client is on carbamazepine is the risk of Stevens-Johnson syndrome. So I put the pictures here because I kind of want you to see. I know it looks very painful, but I wanted to see this is what it looks like. And it's kind of like really bad burn. People skin start to peel. As you can see, it's a pretty significant dermatological emergency. But if you notice this kind of symptoms, just take the person to ER. This is known to cause this. So, and on top of this, something to remember is to really kind of monitor for your client's mental status, because it's known to cause hyponatremia, meaning low sodium level in the blood, which can often cause altered mental status, especially in older adults. And lastly, lamotrigine or lamictal. So it's kind of similar to carbamazepine or Tegretol. It's used for depressive episodes rather than mania, and it doesn't work for mania. And the good thing is that it doesn't cause cognitive impairment like Depakote, does, and it doesn't require blood monitoring like lithium and Depakote do. And this is another medication though that can cause this Stevens-Johnson syndrome, the picture I showed you earlier. And people who tend to develop this side effect, they tend to have allergy history to other medications like antibiotics, and some kind of allergic reaction, allergic conditions like COPD, asthma, atopic dermatitis, that kind of conditions that can predispose them to have Stevens-Johnson syndrome. And I think one thing worth mentioning is that lamotrigine is the medication that you want to keep taking consistently. And if your client misses like a day or two doses, then you want to contact their doctor, because Stevens-Johnson syndrome is associated with the quick titration. So if the client misses few doses, make sure it's okay to continue with the current dose. If they miss a good amount of time, then they might have to restart from the very beginning to avoid the risk of Stevens-Johnson syndrome. So that's something to remember. So just to summarize the key points, people with bipolar often take a combination of antipsychotics, mood stabilizers, and or antidepressant. And some medication can be pretty high risk, and side effects should be closely monitored. So for lithium, make sure the person's hydrated. If they start vomiting or having diarrhea, pay really close attention. And for Depakote, some people get sleepy, gain weight, lose hair, liver issues, but overall well tolerated compared to other ones. And carbamazepine or Tegretol, watch for a rash and low sodium or altered mental status. And lamotrigine or lamictal, again, watch for a rash. If patient misses doses, contact PCP or psychiatrist to kind of see if we need to restart it again or not. And I think that was all I had. Yeah, thank you for your patience. I don't know if it was helpful or not, but hopefully I could highlight some of the things about the psychotropic medications.
I have a question about the Depakote. You were saying about monitoring the blood.
Mhm.
So how often do they need to get a blood test, and do they need a full CBC, or what do you, because I've actually had a resident that's been on that since I got him. I've had him for about 3 years, and I don't remember the doctor ever doing blood tests other than his annual blood tests. So
it's probably okay. What we typically do is that when we change the dosing, increase the dose or decrease the dose, then we check the Depakote level. And as long as everything stays the same, or unless there's a concern for giving too much or something, then I probably wouldn't check the blood. So in your client, it sounds like that this person has been taking it for a long time and tolerating it okay without signs of toxicity. So
Yes.
yeah, I think if that's the case, then we don't have to check it. It's pretty well tolerated. So
Okay, thank
yeah.
you.
Mhm.
There was a question in the chat if there is a way to have this presentation shared with the participants.
Oh, sure. I can do that.
Can there be a link sent out to in the chat box, or would you prefer getting email addresses from those who'd like it?
So I
Probably.
can put the website, our website link in the chat box right now. All of our sessions are recorded and put up on the website underneath the tab Echo Recordings. And then we put up resources under monthly presentations and resources. So you can go there to view this recording at any time. And we can also make the PowerPoint if Dr. Shimizu is okay with that available under the monthly presentation resources so that you can download them and get them. If you are looking for this website at any time, you can look at our MailChimp, that email advertisement that we send out to you. There's a button on there for you to go to our website. So you can refer back to our emails at any time.
Excellent. Thank you so much, Michaela. I don't see any more questions in the chat box. Oh, here's one. Patients should still be getting routine care, though, including blood work such as CBCS, annual, or another appropriate time frame for the individual. Was a comment made?
Yeah, I agree.
Any
Yeah,
other
I think-
comments, questions, or discussion? Go ahead, my apologies.
Oh no, yeah, I think regardless of medications that the person is on, it's pretty important, you know, especially people who are on antipsychotics, including CBCs, BMPs, and then lipids and hemoglobin A1C. And unfortunately, there are a lot of you know, medications that we use in psychiatry. It does affect a lot of you know, metabolic labs and other kind of like really basic physiological functions. So yeah, I totally agree that we should definitely monitor those labs. And depending on the person, like what the person is on, they have a different parameters that the doctor should follow in terms of the routine, like what to check and which intervals. So yeah, I totally agree. Thank you for the comment. Having the
Excellent.
residents-
Another comment was, would you recommend having the residents see their primary care, geriatrician, or psychiatrist when managing either diagnosis?
I think for the psychiatric conditions, it's probably good. I mean, geriatricians are wonderful. Compared to any other like internal medicine specialists, the geriatricians are the most knowledgeable of psychiatric conditions, in my opinion. So it kind of depends on their comfort levels too. But for people who are getting older, things get really complicated in any aspect. You know, sometimes they can kind of, you know, their cognitive function decline, or sometimes, you know, the dementia kind of starts kicking in. It looks like, you know, psychiatric things, or it looks like psychotic disorder when they're really having, you know, BPSD or behavioral or psychological symptoms, dementia. So those nuances are a little bit hard to really diagnose. And depending on what's causing certain symptoms, the management will be different, like medication choices will be different. So it's probably worth seeing, of course, I'm assuming that the person has PCP or geriatrician, and it's probably worth referring the person to some kind of psychiatric provider for diagnostic clarification, especially as you can see, you know, psych meds are pretty high risk. And if there's dementia involved, that's even more high risk. So yeah, I would say if the thing is that it's really hard to find psychiatrists, I think. If there's a chance, I think it wouldn't hurt to have psychiatrists kind of see that person and see what they think. And what I like to do, I think the standard of practice actually is that the psychiatrist and the PCP, they're in touch, they're in communication and they talk to each other to kind of, clarify the situation, clarify the diagnosis so that everybody's kind of, it will be on the same page. And so that there will be no duplication of medications. They both kind of agree on the medications that the person should be on. And, in terms of management, or the monitoring of bloods and things like that we mentioned earlier, we want to coordinate, right? The PCP and the psychiatrist or specialists. So in ideal situation, that kind of things can happen. Hopefully that kind of things will happen to every patient that we have. And if psychiatrist is not available, sometimes consultation is available. And I think it's worth considering that, the person might not be followed by psychiatry, but the person might be seen by a psychiatrist once or twice just for diagnostic clarification and recommendation. So that might be another option.
Definitely the importance of the care team collaborating together for issues like this.
Definitely.
Yeah. There is a request that you could flip back to the very first section, the key points in your first section. And there are more questions coming into the chat box as you're flipping back to that section.
Okay.
And I think it was just for reference for one of our participants.
Okay, let me open this. Sorry. Okay, let me share my slides. Do you see it? So,
Should be popping up here soon. I don't see it yet. There it comes. Okay. I think it was just the key points in the very first section that's requested.
this one?
Perfect. Yes, thank you.
Okay.
All right, going back to some of the questions in the chat. Maribel asks, is there any holistic method in overcoming hallucinations in patients without any medication or diagnosis?
Yes. So it depends on like what's causing it. Hallucinations, and it kind of depends on what kind of hallucinations that is. But some people do deal with it with therapy. Well, you know, just because the person is having hallucination doesn't mean that they need to get treated with medications. When I see people with, say, like hallucinations, they see things or hear things that's not really there. I don't really care as long as the person is okay. You know, some people actually perceive the hallucinatory experiences as positive. You know, they find them supportive. If that's the case, I mean, you don't have to do anything about it, honestly. And what in case of, you know, hallucinations causing issues, you know, any issues that raises concern for safeties, or any issues, you know, leading to behavioral dysregulation that kind of disrupts, you know, the daily flows, that's when it becomes problematic. When the person is cognitively intact enough, they can address by therapy. What it is that you kind of work with the therapist to kind of say, okay, you know, you see this or you hear this, but other people don't. It seems like this is, you know, interrupting your life in this way. How can we work around it? So it's really highly individualized process. It's kind of hard to give examples, but so for example, when I had the patient, you know, this person actually was blind, and it's really common for people who are blind to experience visual hallucinations. It's called Charles-Bonnet syndrome. But so my patient was blind, and then the person was seeing, you know, people, or, you know, they're pretty sure about having this people figure or animals or whatever in their rooms when they cannot really see. So by definition, it's kind of like visual hallucinations. But we kind of talked about, okay, you know, when you're bothered by this, how do you deal with it? You know, and then we can kind of help them develop insight into that. fact that this is not based on truth, they don't have to worry about it. They don't have to feel too scared about it. And also, once they have some insight into, or they develop some kind of reality testing abilities, then you can kind of say, okay, what do you want to do about it? What are some things that you can distract yourself to deal with it? What are some, things that you can do to kind of, address the anxiety caused by it? Things like that. So if the person is able to engage in that kind of cognitive work, then, a person doesn't have to take medications. They can live with it. So it might be there, it's going to be there, but it doesn't mean that it has to, completely go away. As long as the person can live with it in a healthy way, then that's the way to go. Did I answer your question?
Excellent. Thank you so much. Sarah has a question. How does an underlying history of schizophrenia and or bipolar disorder impact a person with new onset dementia?
That's a really interesting question, because the thing is that at least for schizophrenia and any thought disorders or psychotic disorders, people tend to develop dementia earlier, or the psychotic disorders affect cognition to begin with. So they are more prone to developing, major cognitive disorder. So, and people certainly do, right? I mean, anybody can develop dementia, and what to do. So you might see some of the, psychiatric symptoms getting worse with dementia, and certainly cognitive function can get worse too. So we might have to adjust the medications according to that. And also, the thing about dementia is that it's a progressive disease. It's not going to get better. At best, people can kind of stay in that function, hopefully for a while before they kind of, start to really decline. But regardless, it's going to get worse. So with their, physiological changes too, we really should monitor them a little more closely and adjust the medications accordingly. And sometimes there are some times that with the initiation of dementia, some of the psychiatric symptoms might get better, or it might be replaced by other things. So again, it's really difficult to say as anything in geriatrics. So you kind of have to look at that person. But I will say, I mean, if I'm seeing my patient with, serious mental illness, who's entering in a geriatric age, I will probably start doing things like MoCA or MMSE or some kind of, cognitive test or something to follow them, to kind of really understand how's their trajectory, what's their baseline at this time, and then have them, come back at certain intervals and kind of see, okay, how's their cognitive function doing, and how's their psychiatric symptoms doing, and then kind of start to try to get a little more data points to kind of see, okay, this is the direction that this person is going. It's hard to predict what's going to happen, but at least that might give us some clues on how quickly this person is, getting impaired, and things like that. When it comes to dementia, we often think about cognitive decline, but we really don't care about that. I think what's most relevant to all of us here is their functional ability. So, if this person is able to feed himself, or, kind of dress themselves, or any IADLs and IADLs. So those are the things that we really want to look into, because we want to know what kind of, support and resources this person needs. This person might be okay at, say, like, group home setting at this time, but with the dementia, they'll probably need higher level of care in, like a year or so. So bottom line, we have to follow them in longitudinal manner to really get more information on how quickly the change is happening. But I think as a geropsychiatrist, what I'm really interested in is, at this time, at this moment, what can this person do in terms of ADLs and IADLs, and how are psychiatric symptoms impairing those things that we can potentially, treat with the medication that we use, and kind of follow them a little more closely to kind of get the sense of, okay, is this like this kind of decline or that kind of decline? to kind of give a sense so that we can come up with, or I guess we can prepare ourselves for, what's going to happen in a year or two. I don't know if I'm answering these questions, but it's kind of hard because it's very individualized, but it
Case
is
by
true.
case for sure.
Yeah. And then we have to really follow them a little more closely.
Yeah. There's
Dr.
another
Shimizu,
question from
this is
go ahead.
sorry,
Sorry.
I'm sorry. This is Sarah. Just to clarify, I guess the reason I was asking that question is oftentimes I hear the comments that people that have been diagnosed with schizophrenia, as they get older, they burn out. And I what? So I don't know if you could expound upon that, is whether that's a myth or reality, that does schizophrenia disappear as people age?
I see. I have heard of that, it's not like it's gonna disappear per se, but they are not as, I think it becomes less relevant, I guess, in the sense that, with dementia, the people do present with cognitive decline. They present with functional decline. Overall, things are kind of going the same direction regardless. So their starting point might be different. People with serious mental illness, they kind of start from here. And then, people without SMI might start from here in terms of functional ability, but they're kind of going in the same direction. And, they might be psychotic, they might be delusional, but it kind of becomes irrelevant when you look at the whole, picture of how their lives are. Does that make sense? It kind of all gets mingled and all kind of like mixed up. And because the thing is, sometimes, or it's really common for people to have BPSD or behavioral and psychological symptoms of dementia, hearing things, seeing things, delusions and those things associated with dementia itself. They don't have any psychiatric history whatsoever, but once they get dementia, they present with those symptoms. I think one of the studies showed that over 80% of people present with psychiatric symptoms when they get dementia. So, and then the treatment is similar. We some people respond to antipsychotics, and we might have to use it sometimes. So in that kind of big picture and big flow of things, it kind of becomes everything will take the same, I guess, disease path. Yeah, but that's very interesting you brought it up, because some people argue that, people with schizophrenia, they get quote unquote better, or, they get bothered by their symptoms less as they get older, but it's kind of like the opposite. It can be opposite for people with bipolar. I've heard of this a lot from more experienced geri psychiatrists, that their mood symptoms, especially mania, becomes really hard to treat. So again, I think it kind of depends on which diagnosis you're dealing with.
Thank you for that. We're running a little short on time, so we have one more question that I can get to. There are so many more questions in the chat box, but this is a good one. This meeting has great information. How can we get more resources to help us with our clients with this issue, with psychological issues?
That's a really good question that I'm trying to kind of explore myself too, because I know Dr. Lu is, goes to nursing homes and all these different things, and then he does a lot of work around this topic. But there aren't too many resources for people, for geriatric psychiatry. And I'm thinking about, the resources for psychiatric research for psychiatric conditions or serious mental illness. And a good place to start perhaps is the NAMI, NAMI, and Hawaii has a branch. So they've got a lot of information, not only on, psychiatric illnesses, but the resources for the families and caregivers. They have, different groups. and it's a national organization. So if you want to participate in it, you can make a lot of connections there too. So that's probably a good place to start. For dementia, you probably know this already, but Alzheimer's Association, and I think that's probably a good place to start. Yeah, I'm wondering what kind of resources will be helpful. Thankfully we had this platform, but is it going to be helpful to have other seminars like that, or what kind of things are missing? I'm not really sure in the community, so I'll be really curious to hear your kind of input in this. Again, I don't think I'm answering the question directly, but
That's great. Thank you all for so many great questions and participation today. That was an amazing presentation. I think we're going to toss it over to John for our next set of slides.
Hi, everyone. So as a reminder, we are asking that everybody fill out evaluation information, including a medication review. I just placed the link for our evaluation in the chat box, and I will put it in there a couple of more times. But after you complete this, you'll get an email that will take you to this survey. So we ask you to complete it. And thank you for taking so much time to complete these evaluations. As a reminder, we are grant funded, so we are able to provide this to you for free because we do collect some of this information for ourselves. John, can you forward? A little COVID update we have for you. As a reminder, the public health emergency is ending on May 11, 2023. John, go ahead and forward another one. At that time, the cost of vaccines, testing, and treatment will no longer be covered by the federal government. So when the public health emergency was signed in 2020, the government collected all this money and were able to distribute it fairly quickly to help combat the COVID-19 pandemic. And when this emergency act expires, they'll no longer have that funding to distribute for things like the vaccine anymore. There is a supply of federal vaccines that will be available until it runs out. And then after that, our insurance companies will be required to pick it up. So we encourage all of you to go get the bivalent booster if you haven't already, and to get it for your residents if they haven't already gotten it as well. Continue vaccinating as frequently as is recommended by the CDC and the government. Go ahead and forward again, John. And then just as a reminder, the evaluations are sent out with an automated system. We are messing with our automated system a little bit. We understand that quite a few of you didn't receive your certificates last month and had to follow up with us. If that was you didn't get your certificate last month, please email John. I put his email in the chat box, and you can CC me, and we will help you get the one for last month. For this month, please complete your certificate, your evaluation by Monday. We will send out certificates on Monday. And if you haven't gotten them by Monday and you've checked your spam folder, please follow up with us as well. For next month, we'll be trialing a new system that hopefully won't be as buggy. I thank you for being patient with us sending these out. We do send out over 300 a month oftentimes, and it takes quite a bit of work. So I'm very happy if you have gotten yours, and if you haven't, please follow up with us. We appreciate you guys coming and attending and learning with us and participating in this community. Okay, John, go ahead. We're going to pass it off to Mariko. Oh, you're muted.
Sorry. Thank you, Michaela. Thank you, Dr. Mariko Shimizu. That was a great topic. Psychotropic medications are very integral part in managing our clients' behavior. Learning and understanding these meds are very helpful and important to us caregivers, since a lot of our clients have these medications. On behalf of Dr. Redondo Fernandez and Dr. Ada Wynn and the rest of the hub team, thank you all so much for participating today, and hope to see you all next month for managing pain from Dr. Wen. And happy Easter to all. Thank you, everyone. And don't forget, do your survey to get your certificates.
Thank you, Madam. Thank you, everyone.
Thank you. See you guys next month.
Thank you so much.
Happy Easter.